Okay, so I'm Rachel Damone, as it says. I'm a consultant neuropsychologist, and I'm a professional lead for a number of services at Lancashire Care. So the services that I lead include older adult, learning disability, stroke, bit of weight management, and I lead a separate neuropsychology service as well. So hence why I put some services, because when I started listing them, I ran out of space. So although I'm professional lead for these services, I'm not a clinical expert in any of them, some of them. So I've sought thoughts and comments from some of my colleagues, and by that I mean I've heavily plagiarised what they said to me and put it on some slides. And I feel the need, after hearing such inspiring talks, to say this feels really rather dry, and I hope it doesn't put people on a downer. But I do feel I need to be the voice of some of our more Cinderella, smaller, niche services, as my trust likes to call them. Not sure what they mean by that exactly. Okay. So my main point, I guess, around this is that for the services, learning disability and older people, there's very brief mention, really, within the report, and there's quite a lack of attention to dementia and crisis responses. And we know for older people, crisis responses, crisis teams are very, very different. If you're an older person with a crisis at 11 o'clock at night, you won't get the same service as someone who's of general working age adult. And I wondered if that's just because it's felt like it's been dealt with elsewhere. Might be. Just wanted to mention this quote here, which talks about older people's services and the issue around bespoke older people's services. That they should be the preferred model until general mental health services can be shown to provide age-appropriate care. And I suppose my question around that is, how will we know when age-appropriate care is being provided? And a report came out from Age UK just last month, hidden in plain sight, and just a couple of examples from that. So 2011, a target was set for 12% of referrals to IAP to be for older people, and that stands at 6.1% currently, so we're not achieving that yet. More concern, I guess, is the British Journal of Psychiatry paper that compared the needs of the ability, rather, of older adult and general adult services to meet the needs of people with enduring mental health problems, and the older people who received services from the general adult service had twice as many unmet needs after treatment. So Age UK have pointed out that that's concerning, and I would of course echo that as well. This feels like a really bland comment, but IAP really does need to consider the needs of older people and people with a learning disability and autism. And there have been some initiatives around the country, older people's champions and specific interventions for older people, particularly within IAPT, but this really needs to be built on. And the consideration of those needs, it's that kind of thing as Duncan was just saying about the third sector, it's not something you get to the end of it and then go, oh, does this quite fit for older people? No, we'll just add a paragraph. And they need to be central to the whole planning of that and not an add-on. Right, on to physical health, and I should credit Jessica Reid at this point because she's the person I've heavily plagiarised off for this section, it has to be said. So, what she pointed out, and what we've both seen in our own services, is that attending to people's emotional needs doesn't always mean that they need psychological therapy from a psychological practitioner. And if we go right back to everybody's business, it's about remembering that everybody should be able to manage distress to some degree. I think we've both had really good examples of working with IAP, but also examples where it's not gone so well, and things like home visits, shorter sessions, not discharging people who miss a session because they've had to go into hospital, for example. We know that not everyone who's distressed and has a physical health condition will be experiencing clinical levels of anxiety or depression, but their distress might still be impacting on that physical health care condition, and Jackie spoke about that earlier as well. I think all the speakers have spoken about social care and social issues being absolutely crucial to this. Money, isolation for older people, engagement with others, really, really challenging. So there's been quite a number of high-profile projects that have delivered their change through cultural change. So the RAID model in Birmingham, the North West London Diabetes Collaborative. Jackie mentioned how poor mental health can increase the cost of physical care in diabetes by 50%. That's a huge amount of money. And the way these have achieved their gains is through being really embedded in the services that allows opportunities for consultation and conversation. And there is an issue about that kind of work not being counted currently, and that's something we need to be really mindful of. So our model of psychology input into stroke services tells a similar story. So the person is embedded in the team and they support those low-level interventions that keep people well, so people don't need to be seeking out more formal psychological therapy necessarily. In East Lancashire, we've commissioned somebody's commissioned mental health practitioners to work into integrated neighbourhood teams, which are largely physical health teams, district nurses and the like. And they've just recently won a Positive Practice in Mental Health National Award for that work. Right, I have a bit of a bee. Do I have a bee in my bonnet? I think I do have a bee in my bonnet about medically unexplained symptoms, so I'm going to indulge that bee just for this slide. So, to take a quote from the report, 2/3 of additional people receiving services will have in the future comorbid physical and mental health conditions or persistent medically unexplained symptoms. And for me, medically unexplained symptoms and physical health and long-term conditions are completely different things, and they shouldn't be grouped together. So that planning needs to recognise that patients with MUS, as it's nicely called, can be very complex. They make up a vast amount of referrals to my neuropsychology service. So we really need to think about training and supervision of staff expected to work with those groups. And despite not always meeting the holy DSM criteria or presenting in crisis, patients with MUS or NEED, and NEED stands for non-epileptic, if I can say it, non-epileptic attack disorder, they can be highly complex. So I wonder if saying that top-up training is perhaps a little bit overly simplistic in that case. It's a very broad-ranging category, MUS, through from unexplained pain, fatigue, right through to severe functional movement disorders that need inpatient admissions and so on. Again, there's some great work happening in these areas in some primary care services, but these services also need to allow for those people needing more complex input. Concluding comments, I'm afraid I added a few extra bits in, so it's not really a neat summary of what I've spoken about. But coming back to the positives, because there are loads of positives from the report, I really welcome the focus on recognising the lack of parity of esteem across mental and physical health and the huge range of inequalities across the board. But there are no sections dedicated to older people or people with a learning disability, and there's no sections talking about dementia care. There's an issue around integrated care, because we talk about integrated care a lot, but actually, do we know what it looks like and do we know how we can achieve it? There's a link there to the thing called the National ELF Service. I don't know if anyone's come across that, but that talks about, it's a piece posted by someone called Liz Hughes that briefly summarises a rapid review that was undertaken by Rogers and colleagues. And that was around informing understanding of integrated care this year. And the conclusions drawn here suggest we need to be much better informed before we start creating new and possibly ineffective integrated models. We need to know how they work, for who they work, and why they work, particularly in severe mental illness. One of my LD colleagues was keen to raise the point about staffing and recognising that a range of staff and therefore bandings would need to recognise the complexity and diversity of the presentation staff would be expected to work with. For me, staff wellbeing has to be an absolute priority. Noting the national survey, was it just last year, Geeta, around the really high rates of depression in psychological professionals, especially in IAP services, especially around targets that people are expected to meet. And that support can't be tokenistic. It can't be refer someone to occupational health. It needs to be a really strong range of initiatives. So at Lancashire Care, we have the Schwartz rounds as a really good example, reflective monthly space for people to talk about the emotional aspects of their work, but there needs to be a full range, and staff really need to be supported to do more work and more complex work. So we need to really think about, again, appropriateness and outcomes, not just access, because you hear that talked about, we need to improve access. It's about, is it appropriate, and are we getting the outcomes that people want, that people set themselves, for people who are older, people with a learning disability, and people who have neurological deficits. So just a final point. Current roles, service models and so on, they may work well for pure mental health issues, but then we may need to look at them again to think about how they deliver integrated care, as opposed to just easier access to psychological therapy for people with physical health issues. So both laudable, but they are different things. So I'm very much looking forward to hearing from some of my colleagues actually this afternoon who are talking about IAPT and long-term conditions in my particular neck of the Lancashire woods. And hopefully that wasn't too much of a downer for people, not too dry. I won't wait for a response on that. But there are a number of opportunities, and it would be great this afternoon to move on to think about those opportunities and how we achieve them. So thank you.